And without further ado, I'll go ahead and introduce our first speaker, Jim McClelland. In January 2017, Governor Eric Holcomb appointed Jim McClelland to the newly created position of Executive Director for Drug Prevention, Treatment, and Enforcement for the state of Indiana. He reports to the governor and also chairs the Indiana Commission to Combat Drug Abuse. Jim is charged with coordinating, aligning, and focusing the relevant work with a wide array of state agencies that touch substance abuse issues directly or are indirectly related to those issues. In addition, he seeks to leverage the state's resources with those of entities in other sectors to respond as effectively as possible to the current opioid crisis and to substantially reduce the likelihood of a similar crisis arising from the abuse of addictive substances in the future. In 2015, Jim concluded a 45-year career with Goodwill Industries, the last 41 of those as president and CEO of Goodwill, based in Indianapolis. He has served on the boards of numerous nonprofit organizations at local, national, and international levels and chaired several of them. He currently serves on the Dean Council of the Indiana University Kelley School of Business, Indianapolis, the advisory board of the School of Industrial and Systems Engineering at Georgia Tech, and the board of directors of Building Tomorrow. A native of Florida, Jim earned a bachelor's of industrial engineering degree from Georgia Tech and an MBA from the Kelley School of Business at Indiana University. He's married to Jane, and they have 2 grown children and 2 grandchildren. Welcome, Jim.
Thank you, Robin, and thank you for the opportunity to talk with you today. I've been asked to provide an assessment of the state's progress to date in responding to the opioid crisis and paying particular attention to inspect and to prescribing guidelines, and also to comment on the governor's 2018 agenda. And while I'm aware that most of the people in this room are quite familiar with various aspects of the opioid crisis, but for those who might not be as knowledgeable, or those who might be listening or watching at some future time, then I'm going to provide some background and context. I'll put all of my remarks in a larger context. In 2015, there were more Americans who died of overdoses than the number of Americans who died of HIV and AIDS at the height of that epidemic in 1995, and last year there were more overdose deaths than the total number of Americans who were killed in the Vietnam War. Overdose deaths in Indiana rose 40% last year. They've doubled in the last 3 years. Officially, our death rate is 17th highest in the nation. This epidemic has been developing for 20 years. It got its start with the overuse of legally prescribed opioid pain medications, a consequence of what turned out to be an ill-advised movement starting in the 1990s to recognize pain as the 5th vital sign, along with misleading marketing of OxyContin by Purdue Pharma. Opioid prescription rates in the U.S. have come down from their peak in 2011, but are still 3 times what they were in 1999. In Indiana, the opioid prescription rate has come down 25% over the last 4 years, but it's still the 11th highest in the nation and at 23% higher than the national average. We've got a ways to go yet. But last year, 1.6 million Hoosiers, different people, 24% of the entire population of the state, received at least one prescription for an opioid. When I heard that, it floored me. That was a staggering percentage to me. Persons addicted to opioid pain pills are 40 times more likely to become addicted to heroin. 75 to 80% of heroin users start out abusing pain medications. And while overdoses and deaths from prescription pain pills remain a problem, deaths from fentanyl and other synthetic opioids are soaring, typically laced into heroin and, alarmingly, increasingly now into other drugs. You buy something on the streets, folks, you have no idea what you're getting. But I will tell you, there is nothing about this epidemic that troubles me more than the impact on children. Every 25 minutes, somewhere in this country, a baby is born with neonatal abstinence syndrome. There is no more innocent victim of anything in the world than a newborn who has to go through withdrawal. 2/3 of all child maltreatment cases involve parental substance abuse, and the number of children removed by DCS because of parental substance abuse rose 22% from 2015 to 16. Those situations now account for 52% of all cases. We've learned a lot in this country over the last 20 years about the long-term effects of adverse childhood experiences, ACEs, if you will. SAMHSA reports, for example, that for every additional ACE, the rate of prescription drug use increases 62%. And each ACE increases the likelihood of early initiation of illicit drug use by 2 to 4 times. I will tell you, if we as a society don't do enough to help mitigate the impact on all of these children, we're going to pay a heavy price 10 or 15 years down the road. There are workforce and economic implications to this epidemic. There are a lot of employers who tell us they can't fill all their vacancies because they can't find enough applicants who can pass a drug test. And last month, the White House Council of Economic Advisors estimated the true cost of the nation's opioid epidemic in 2016 at over $500 billion. As I'm sure everyone in this room knows, this situation affects people in cities, suburbs, small towns, and rural areas, and it cuts across all socioeconomic lines. There are at least 2 mayors of cities in this state who have grown children with substance use disorder. And a few months ago, the son of the mayor of Nashville, Tennessee, died of an overdose. A major problem is that only about 1/10 of those who need treatment are getting it, and of those, only about 1/3 are getting evidence-based treatment, which is medication-assisted treatment. The sad fact is, it's far easier to get high than it is to get help, and we got to change that. So what are we doing? Governor Holcomb, from the outset, has made attacking this problem one of his very top priorities, and that will continue to be the case next year. You heard in the introduction what my role is. Basically, it's making sure that we're all moving in the same direction as far as state agencies are concerned, and to leverage the state's resources as best we can with those of other sectors: business, higher education, healthcare, philanthropies, faith-based organizations, other organizations, trying to bring the pieces together and leverage resources in a way that is going to give us the best chance to have the greatest impact in dealing with this problem. And it is a very complex problem. And the more you learn about it, the more you realize how many pieces there are to it. And we have to act on multiple fronts simultaneously. But there are no quick or easy solutions. There are no silver bullets. There are no panaceas. We can and we should attack the supply side, especially to disrupt the supply of fentanyl. And the governor's 2018 agenda includes establishing a felony charge for drug-induced homicide and a felony murder charge for those who illicitly manufacture drugs that result in drug-induced death. But while we need to disrupt the supply of illicit substances, the long-term solution is to greatly reduce demand. Now, in the spring, we put together a strategic approach to this. A framework, if you will, to help guide us in decision-making. Otherwise, it would be very easy just to play whack-a-mole. You throw a little bit over here because that's a problem, and you throw a little over here because that's a problem, and oh yeah, there's another one out there. And all of these might be individually worthy things to do, but they might not be the highest priorities, and they might not be connected with each other in ways that are going to enable us to have the greatest possible impact. So we put together this framework. We also have to realize we can't do everything at once, and we have to recognize there are no perfect solutions. We cannot let the perfect be the enemy of the good here. And if this is the level where we are today, and this is where we want to be, but right now this is as far as we can go, then let's go there. Let's get there, and then let's continue to work to close the gap, and let's do it with as strong a sense of urgency as we can possibly maintain. We have 3 broad priorities. One is to do everything we can just to help keep people alive. A second is to greatly expand access to treatment when and where it's needed, and along with that, to expand recovery supports, including recovery housing. And then to do everything we can to help prevent more people from becoming addicted to opioids or other addictive substances. And certainly part of that has to do with continuing to bring down prescription rates, opioid prescription rates, and increasing the use of alternative pain management treatments and therapies. We also have to do a lot more to educate and inform people about the nature of this problem. We have to do a lot more to reduce stigma. And then we have to do as much as we possibly can to prevent or at least delay as long as possible the use of addictive substances by young people. I'll speak a little bit more on each of these major priorities and some of what the state is doing. Doing what we can to help keep people alive. A lot of that has to do certainly with the distribution of and access to naloxone, but then we need to be getting more people into treatment as quickly as possible. And one approach that we're going to replicate is Project Point, which is underway at Eskenazi here in Indy. It's a warm handoff to treatment with a recovery coach in the emergency department to help connect people who have been revived from an overdose and help connect them with treatment. We're going to place recovery specialists in several emergency departments in high needs areas around the state. Other steps we've taken this year. The governor announced several months ago we're going to establish 5 new FSSA-approved opioid treatment programs. Locations were determined by an analysis of data on need versus availability of treatment. And the governor's 2018 legislative agenda calls for adding 9 more FSSA-approved and monitored opioid treatment programs so that by the time we get all of these underway, everyone in the state will be within an hour's drive of such a facility. Earlier this year, we also made a policy change so that Medicaid can now pay for methadone treatment. As I'm sure most of you know, maybe all of you know, there are only 3 drugs that are approved by the FDA for treatment of an opioid use disorder. We need every available tool in our kit. Every one of these drugs works for some people. Not one of these drugs works for everybody. We need them all available to us. We're also supporting pilot programs that were authorized by the General Assembly in the last session of the legislature. 2 of those focus on new moms and their babies. We're establishing several mobile crisis intervention teams across the state, strategic locations, and the state has awarded a contract to the IU School of Medicine to offer Project Echo webinars for providers. One of the benefits of this is going to be to enable more doctors to receive the training that they need so they can get a DEA waiver that will enable them to prescribe buprenorphine. And we're expanding the use of telemedicine to better serve rural areas. The Indiana Hospital Association and the Indiana State Medical Association have been working together to develop CME modules on substance use disorder for providers. Those associations have also been working together on prescribing guidelines. And something that's really important, several months ago we put in an application to CMS for a waiver that would enable us to use Medicaid dollars to pay for residential treatment and recovery support services. This, folks, this could be a real game changer that would bring another $60 to $65 million a year into the state for those services and would enable us to expand residential beds by about 50% to 1,200 statewide. And with the use of a modified open beds platform linked with statewide 211 system, which is also part of the governor's agenda for next year, but this is administrative rather than legislative, it's going to enable us to make better use of the existing capacity, much more complete use of the existing capacity. The Department of Correction is making a number of improvements in how they treat individuals who are incarcerated and who have substance use disorders, and they're working with FSSA to link people with treatment outside before they're released to ease the reentry process. We know that 2 big needs for people who are coming out of the correction system or for people in recovery, and certainly those populations overlap, they need a decent place to live and they need a job. And we're working on ways to better link the need that a lot of employers have for workers with the need that people in recovery have for jobs. We really have an opportunity here with a very low unemployment rate in the state. We've got an opportunity that may not always be with us. FSSA has also launched an anti-stigma campaign, termed a humanizing campaign. It's been launched. We have a lot of work to do to reduce stigma, and we've also established a website, in.gov/recovery. And this is behind the scenes, but it's really important. Nearly 20 state agencies have signed an agreement to share data with the Management Performance Hub in the State House so that the MPH can now bring data sets together from various disparate sources, even just within the state government as well as from outside, and convert that data into more useful, timely, and actionable information. And a great example of leveraging resources is IU's decision to make responding to the addictions crisis its third grand challenge. And IU has made a $50 million commitment to this over the next 5 years in 5 key areas: data sciences and analytics, education, training, and certification, policy analysis, economics, and law, basic applied and translational research, and community and workforce development. Now, this grand challenge will be front-loaded with 16 projects set to launch in the very near future. Additional projects will get underway in mid-2018, and there will be a preference for projects that have potential for application within a short time frame. Now, on the prevention front, we are working to continue to reduce opioid prescribing rates, and to aid in this, the state is paying the fees to integrate and inspect our prescription drug monitoring program with the electronic health records and pharmacy management systems statewide. That work is well underway, and early reports are very positive. It's taken a system that for the most part was slow and cumbersome, and it's made it fast and highly user-friendly. Deaconess piloted the integration and is now using it system-wide. Other early adopters have included Kroger and Meijer, and I'm told that CVS will go live statewide by the first week of January. Others where the integration process is underway include community hospitals, St. Joseph Regional, Franciscan, Clark Memorial, Community in Munster, and King's Daughters Health in Madison, among others. As of yesterday, 112 facilities have gone live, 266 more are in the process of being integrated, 53 more are signed up, but the timeline for integration has not yet been confirmed, and those figures do not include IU Health, which last week signed an agreement to integrate their entire system. It'll take about 3 years to get to complete integration, but it's moving ahead at a very good pace. Also aiding in prevention is Senate Enrolled Act 226, which became law on July 1, and which establishes a 7-day limit on first-time prescriptions of opioids for adults and a 7-day limit on all opioid prescriptions for persons under age 18. Exceptions can be made for cancer, palliative care, medication-assisted treatment for a substance use disorder, and any other condition where, in the professional judgment of the physician, the patient needs more. But upon request of the patient or patient's parent or guardian, the prescriber may write the prescript for a lower quantity, and a pharmacist may, upon request, partially fill a prescription. Now, the governor's 2018 agenda includes a proposal to require physicians to check and inspect before issuing first prescriptions for opioids and benzodiazepines. 8 states currently require system inquiries before issuing the first prescription, and in states with required use, there have been reductions in the number of opioid prescriptions and reductions in harmful combinations of drugs. The governor's proposal will have to work its way through the legislative process, and the requested effective date will likely be far enough out to allow for near complete integration of Inspect with the electronic health record systems. The 2018 agenda also includes improving the state's reporting of overdose deaths to increase consistency and knowledge about the scale of the problem. This will involve requiring coroners to order more detailed toxicology reports in cases where overdose deaths are reported, and require that results be submitted to the State Department of Health. This is currently being piloted in 6 counties. Now, in addition to continuing to bring down opioid prescription rates to reduce the prevalence of opioid use disorders, we also need to do everything we can to prevent or at least delay as long as possible the use of addictive substances by young people. There is solid data showing that the earlier a young person tries alcohol or drugs, the more likely they are to develop a serious addiction problem later in life. And in my travels around the state this year, I've met a number of people who have or who continue to struggle with, who have struggled or who continue to struggle with an opioid use disorder that began when, by choice or as a result of a legally prescribed pain medication, They developed this when they were in their teens. One is Brandon, who was a suburban kid who liked to party. He started with alcohol, then marijuana. Then he became hooked on prescription pain pills, and then he turned to heroin. It took him 10 years, several treatment programs, and many thousands of dollars of his parents' money before he was able to stay sober. But he's now maintained recovery for nearly a decade, and he's doing well. Another young man whose family I've had a lot of contact with this year developed his addiction after taking opioids following an appendectomy when he was 15. He's 23 now, and he continues to struggle in and out of jails and treatment programs. Another 23-year-old young man in the northern part of the state developed his addiction as a result of opioids prescribed for him following a high school football injury. He continues to struggle. And then just a few weeks ago, a friend of mine had been meeting with a group of high school kids in Angola who were very concerned about this issue and wanted to do something to help. And my friend asked these students, if I wanted to get something here in Angola today by 3 o'clock, could I do it? And the kids said, oh, sure, that's no problem. And he said, what would I be likely to get? Oh, prescription pills. They're plentiful, they're available. We've got a lot of work to do. We have a lot of work to do to educate the public and prescribers and to reduce stigma. And we also need to expand the use of evidence-based substance abuse prevention programs such as life skills training and strengthening families. And we can emulate other successful examples like Youth First in Evansville or the Youth Assistance Program in Hamilton County. Or we can do more of what Iceland has done to reduce its substance abuse problem among its young people. And some of you may be familiar with this, but for those who aren't, from 1998 to 2016, the percentage of 15 and 16-year-olds in that country who had been drunk within the previous month dropped from 42% to 5%. The percentage who had ever smoked marijuana dropped from 17 to 7%. And the percent who used cigarettes on a daily basis dropped from 23 to 3%. How did they do it? There were a number of steps that they took, but they organized it at a municipal level. And one of the things that was really key was creating a lot of after-school opportunities for young people to do things that they really wanted to do, to learn or enhance skills that they really wanted to learn or enhance. It got them with, it could be art, music, dance, sport. They got them with other kids who had similar interests who might not have been the same kids they would have been hanging out with on the streets, and in many cases it ignited a passion. But what they created were opportunities for kids to get natural highs from doing these kinds of positive activities rather than from using drugs or alcohol. And one way I heard it described was they created among young people a culture built around personal growth and development that could compete effectively with a culture of getting high. We can do a lot more of that in this country and increase protective factors and reduce risk factors. There is an enormous amount of data showing how many of the social problems in our country are interrelated. We saw that in my last career as we were focused on trying to find ways to reduce intergenerational poverty. And it also applies in preventing substance abuse and in helping those in recovery to maintain recovery. But while the problems are interrelated, we haven't often tended to treat them as if they were. We've tended to treat them individually in isolation, one from another. The public sector through its silos, the not-for-profit sector very fragmented, a lot of people doing a lot of things that are really good, but each one typically focused on a small piece of a much larger, more complex problem. And we have not traditionally done a very good job connecting the pieces. And that's what we need to do. We need holistic, often whole family, wraparound approaches. In other words, we need to bring the pieces together to help strengthen families and build healthier communities. With regard to the opioid issue, with so many people dying from overdoses, we must place top priority on expanding access to treatment, when and where it's needed, and on helping those who achieve recovery maintaining. And that's dealing with the immediate problem. But we also need to take actions now to greatly reduce the likelihood of a similar problem in the years ahead. And certainly part of that involves continuing to reduce opioid prescription rates while increasing the use of alternative means of managing pain. In addition, though, we need to do more to help our kids develop, and in many cases, to help parents be better equipped to help their kids. There's more than one way to do this, but the bottom line is we can invest up front to prevent problems, or we can spend a lot more later trying to fix those problems. But to the extent that we're able to bring the pieces together at a community or a regional level, making the most of our collective resources to better enable individuals and families to achieve their potential, we'll not only be strengthening families, but we're also going to be helping to build stronger and healthier communities for all of our citizens. Thank you for allowing me to share these thoughts with you, and thank you for what you're doing to help address this problem.